I think I'm all good, all good. Thanks, Gareth. God, what a way to set me up for failure, mate. Thanks very much. That's all good. Look, a pleasure to be here, and it's a big room, so it's not a great day to have an arrest on the streets of Edinburgh, is it? So lots of crews here. So yeah, this is just a chat. This is opinion-heavy and data-free, right? Because I guess you guys see a lot of undifferentiated arrests, and you are the front line, and I'm conscious that what I see is almost like an ivory tower view, right? So they get filtered out. There are many cardiac arrests that I don't have to see. And so it's just to kind of unmask a little bit of what goes on once they come through our doors, once you've got them through the hospital and it's a cardiac problem, okay? So are there any Aussies in the room? There must be. There's got to be, yeah, all right, yeah. So I know I've met Aussie paramedics in it. You seen this? Seen Kenny? No. Yeah, fair enough. About 2000, Kenny, this is Aussie classic, a fantastic film, Shane Jacobson, highly recommended. And I'm showing this because Kenny is a plumber, okay? And it's important that you all understand a little bit about me, right? Because all your speakers have a little bit of bias, okay? So you've got to understand what are my biases, okay? My bias is I'm a plumber, I'm Kenny, okay? So I'm an interventional cardiologist. I think everything is about the coronary arteries. I see a stenosis, I've got to fix it, and I'm a simple plumber, okay? So cardiologists are not the brainiacs of cardiology. It's probably the electrophysiologists. So for me, I like to keep things really simple, right? So that's Kenny. And I do think the coronary arteries are amazing. Core principles, and this is not just about today, it's just fundamental things which I tell all the registrars which do apply. So I think the basics are really important. So history for patients that we see with cardiac arrest, absolutely crucial, absolutely crucial. When you can get a history, collateral history, can sometimes make all the difference when it comes to diagnosis and management. And you'll not be surprised to hear that a cardiologist thinks an ECG is really important, okay? So more ECGs, the better. Be liberal, use all the paper, run all the rhythm strips, I'll look at them all, okay? So ECGs are really important. And then you don't need me to tell you this, okay? So whatever else you do, whatever needs to be done immediately, and then everything else can wait, okay? So I'm not fussy about a cannula that's in the right radial, okay? It doesn't matter. So you guys do what you need to do, get what needs to be done quickly, and then everything else we can deal with afterwards, okay? So how do we go from here to here, home, okay? So the chain of survival, I guess, talks about a lot of the immediate actions, but really the chain of survival does extend to, ideally, discharge home from hospital. And different patients go through different journeys, right? Some go to resus, some never need to go to resus, some come to the cath lab, some don't come to the cath lab. Some people go to ICU, sometimes some go west, right, to Glasgow if they have shock that's refractory, need a transplant, and some of them go to the ward, and hopefully patients go home. So what happens for us, and what am I thinking about when I see these patients? I will recognise that the most important thing here when it comes to the ward care is that for a lot of these patients, once the immediate stuff is done, the cardiologist is often not very useful, okay? So a lot of the aftercare of these patients is based around nursing care, allied health care, rehab, and I'm not doing very much, okay? So that's really important. It's a real team effort to get these people home. So the emergencies. So initially, the emergency is what you've dealt with, but when you bring them in, say, to resus, and say, Gareth calls me to come down and see the patient, what am I thinking? Okay, is there something that's meaningful that needs to be delivered emergently that is going to change the management of the patient and change their outcome? And do I need to do something now? Okay, so that's the first thing that's in my mind. And what are these things that cardiologists can help with? Because, you know, if this is a non-cardiac cause, there's not much necessarily that I can do. Okay, so this is for cardiac problems. I like to keep things simple. Number one, ischemia, obviously. Are they having a big MI? Okay. Number two, is this a refractory arrhythmic problem? Okay. So some of these patients have a primary arrhythmia. Are they in some sort of refractory arrhythmia? And then for me, number three is, are they in terrible shock? Okay. Are they in pump failure, usually, or obstructive failure, but mostly pump failure? Cardiogenic shock for some reason, and they're dying from that when they come through the front door. Okay. Simple buckets for me, and therefore, the answers can be, broadly speaking, relatively simple. So what's the answer for someone to have an infarct? Open the artery, okay? Easy. Everyone knows what this looks like. Everyone probably looks at this and probably thinks that's not very nice. So right bundle, anterior STEMI. That needs the LED opened, okay? How do we assess these patients? ECG, 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 okay? History, echo, useful, okay? We'll come in, stick the probe on. If there's any ED physicians here, POCUS, okay? And then blood gas will be very useful for prognostication often. Ugly, everyone will agree? Don't like saying this, okay? Yeah, it gives you heebie-jeebies. This is someone who's obviously having paroxysms of VT, and this is an arrhythmic problem, okay? So, ischemia, open the artery. So bearing in mind that ischemia doesn't necessarily mean it's an infarct, but if someone's HB is 40, they're probably ischemic. But I'm really referring to an acute arterial occlusion, okay? So occlusive MI, open the artery. What do we do if there's an arrhythmic problem? Okay? It sounds a bit silly, understand the problem, treat it, and it's a bit silly because it's obvious. But the point of this is there can be different substrates, right? So some people can actually have bradycardic VT arrests, right? If they're having R on T and their base rate's really slow, and the paradoxical treatment for them, you've got to speed them up. So you give them isoprenaline, pace them. Other people are having refractory VT because they've got tons of scar from null infarct, and treatment for that patient is probably some sort of anti-arrhythmic like amiodarone, okay? So understand the problem, direct your treatment at that problem. And then if someone's in shock, if someone's in pump failure because they've got terrible cardiomyopathy, we need to either support the heart, support the organs, or do both, okay? And sometimes supporting the organs is at expense of the heart. We have to remember that, okay? And the other thing is, although I've divided these into 3 big buckets, sometimes 1 big bucket, okay? So sometimes the patient's got lots of scar, they're ischemic, and they're having lots of VT, and they're in shock all at the same time, okay? But I like to keep these things simple because it helps direct your treatment. Once we're past that acute stage, now we're getting into the kind of, they're on the ward, or they're in ICU, stewarded somewhere, they're in ICU, they're stable. What are we thinking about the underlying problem? Okay, so now we can get into the kind of cerebral thinking about things. And now I like to divide things into small buckets. What's the underlying pathology driving this if they've become stable? Okay, so first, heart muscle. Is there a muscle problem? Okay, so do these patients have some sort of cardiomyopathy? So hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic cardiomyopathy, or have they acquired some bad thing? Right? They have lots of scar from null infarct, maybe they've got sarcoid and myocarditis, okay? And this is probably the biggest bucket you'll see of patients of heart having an acute MI. It's very common, okay? Next, is there something structurally wrong with the heart? Less common, a bit more niche, probably limited to things like severe aortic stenosis and congenital heart disease, which scares me, and I don't want to talk about it, okay? And the final box, which is less common, but probably some of the worst ones you'll see because these are young patients, are primary electrical problem, okay? So Brugada, long QT, short QT is very rare, pre-excited AF, right? So AF going down an accessory pathway causing VF. So these are scary. They're not common, but they're scary because this is 20-year-olds, 30-year-olds that you guys will see, okay? So that bucket is less common, but scary. And this is the only data slide you'll see, and it's a bit small up here, but this is from 2022, okay? ESC guidelines on cardiac arrest. It's a very useful thing. And all you need to see, so on the left-hand side, they've listed a few different pathologies here. In the middle, you'll see the big plots here of where the peak incidence of these conditions are when they arrest and the age at the top. And for those at the back, I'll talk these through. So those two there, that's acute coronary syndrome and chronic coronary artery disease. You can see that by far, this is the biggest volume, looking at those plots, okay? And the peak incidence is around the 60s, mid-60s, okay? A big wave like that. In the middle, these 3, those boxes there, that's the cardiomyopathy I was talking about, okay? So you can see smaller boxes, slightly younger, and then electrical problems at the top, the ones I was referring to before, okay? Things like Brugada, non-QT syndrome. You can see this is a preponderance of incidence in young people, young cardiac arrests, all right? But the absolute rate, small. So that's really all I want to say. I mean, that's how I kind of think about these patients, and I'm going to compare and contrast two tales, okay? And then we'll finish up. So this is two blokes that have come in, and maybe some of you resuscitate these two fellas. So in the last 2 years, okay, they've come in, and I'll tell you, this is an accurate pictorial representation of what was happening when these two fellas arrested, okay? So that guy, when he arrested, 90, okay? He was walking with his wife. You'll see that at A&E, okay? There's a hospital in the background. He was walking with his wife to his wife's dermatology appointment in the Lauriston buildings, okay? And they got into the building, and he had his arrest, okay? The other fella is 22, okay? And he was running, he was out running, he was at the gym, he was running, and he had a cardiac arrest, okay? So there's two different people, one at the start of a young, fruitful life, and the other fella towards the end, okay? They both had a cardiac arrest. So what's the difference here? So what was the clinical history, because I've said the history is important, in the 90-year-old? So this guy had no antecedent symptoms, although he's 90, fit and well, right? Walking up hills, enjoying life, and he got resuscitated immediately by a dermatologist, okay? So got defibrillated for a VF arrest. Now what's his past history? Really important. Well, 2 years before this, he'd had an anterior MI, okay? But because 2 years before this he was 88, we managed him medically, he's been fine. So after an MI in 2 years before this, he was totally fine, no angina, no heart failure, no symptoms, and on good treatment and good medical therapy. That's his only past history. And mild to moderately impaired ejection fraction. It's a pretty good shape, okay? And then what's he like when he comes into resus, okay? You would not believe it. He was absolutely fine. Sitting up, chatting, wife was there, quite relaxed, nothing wrong. It was like nothing happened to him, honestly. He was unbelievable, all right? So this guy, that's his ECG. So you probably all agree that is not an acute myocardial infarction with a blocked artery, okay? So is there something acute that needs to be done urgently for this man? Don't think so. ECG doesn't show an acute infarct. He's not having refractory arrhythmia, and he's not in shock. So we've got time to think about things. Punt him up to the ward, have a look at him, have a think about what the problem is. It's very obvious, right? This guy's got scar from an old infarct, and he's had scar as the substrate for his cardiac arrest. So this is an ischemic cardiomyopathy. So I remember I got the ED consultant on that day, he said to me, "You're not going to take him to the cath lab?" I said, why not? Well, what are we going to do? So the idea here is that taking this guy to the cath lab is not the answer, right? Because he hasn't got an acute coronary occlusion, right? The problem is scar, okay? And what did I do for this man? Gave him amiodarone, sent him home. 3 days later, it was 2 years ago now, he's fine, okay? So this is medical therapy in an older patient with no symptoms preceding and ischemic cardiomyopathy. He's done very well. And just to show, so this is the same box, right? So he belongs in this bottom box, chronic coronary artery disease. And for those at the back, I'll tell you that the scale of the age goes up to 80. So he's off the chart. He's too old to be on the chart for the European Society of Cardiology, okay? So the next young fella, super active, right? Again, he's got no past history, doesn't take drugs, there's no family history, cardiomyopathy, nothing, right? Except ever since he was a kid, every so often we'd be running, and this guy's a fitness freak, right? Runs all the time. He'd occasionally get sense of palpitations, rapid, but never passed out, never had presyncope, totally fine, and he just always ignored it, okay? So it didn't really trouble him until this day, cardiac arrest, okay, at the gym. On arrival at ED, this man is not fine. He's stable hemodynamically, low GCS, intubated, off to ICU goes. So what's this guy's clinical course, all right? Very different from the 90-year-old. ECG, I'll tell you, this is a normal ECG. There's no hint of any channelopathy, accessory pathway, ischemia, cardiomyopathy. It's normal. Bedside echo, normal, okay? Bloods, normal. Again, obviously there's no acute problem that needs emergency management when he comes in because his arrest has happened and he's stabilized. And so what's his problem? The truth is, I don't know. At this stage, very hard to know. Could be several different early cardiomyopathies. Could be some sort of channelopathy. Don't know. So we do get these patients in, and these are the ones you'll drop off to us, and you might not know what happens to them, okay? So what happens to a guy like this in hospital? So 2 weeks in ICU, pneumonia, line-related DVT, quite delirious, okay, quite delirious. And eventually comes good, okay? And I'll tell you that we did every test we could think of, and they're all normal, okay? MRI, looking for scar, no scar. Various kind of tests, treadmill tests, Ajmaline tests, looking for nothing, okay? And this happens as well sometimes. So at the end of the day, after all these normal tests, I had to say that this was probably just maybe some sort of early cardiomyopathy we just hadn't found, but it's basically unexplained. Unexplained. So we don't know what the problem was yet, so we haven't given him a directed treatment for the cause, but we want to protect him from dying again, obviously. So defibrillator, beta blocker, home, okay? You've all been called out to see patients with defibs who have gone off, I presume. So this young man immediately started running again. Taking his beta blocker, he started getting these palpitations again, and then gets some shocks, okay? Boom, okay? That's what it looks like. So if you get a readout from your ICD, you get this trace, okay? So you can see he's in sinus rhythm, he's tachycardic because he's been running. Then out of nowhere, monomorphic kind of broad complex tachycardia. And then you get a little zap symbol here because that's the zap, that's his defibrillation. He gets a shock. And I'll tell you, he was depleting his battery on his ICD because he said he wasn't taking his bisoprolol, but he kept getting these shocks. And it's obviously unsatisfactory. So the one test we had not done was an electrophysiology study, which the EP guys, remember I said they're the brainiacs, they initially thought probably wasn't going to be very helpful in this case. But at the end of the day, it's a young fella, unexplained. It's the one test we haven't done. Why don't we just do it? So I talked him around to it, and this is a picture, if you ever come to the cath lab, you've seen the coronaries. This is the kind of stuff that the EP guys stick in. So there's 2 or 3 catheters within the heart in different parts of the heart, and they map out different signals and see where everything's coming from. And lucky enough, they did find a cause. Extremely rare, and we're going to put in as a case report. Basically, he had Wolff-Parkinson-White. And he had AVRT, so a tachycardia through the excessive pathway, which was probably what he got shocked for, but he never had AF, okay? So it's very rare to arrest from Wolff-Parkinson-White if you don't have concomitant AF. So this is an extremely rare case, but they ablated it. And lo and behold, immediately afterwards, he's been fine. No symptoms, no palpitations, he's running better than ever. Actually, he's really happy, okay? So this is what happens. We often kind of go through a kind of barrage of tests to find out what's happening in young people, okay? And this guy is nowhere on this chart. He's nowhere on this chart, all right? So that's it. That's all I really want to say. So my final thoughts, I suppose, are from the start. So basics, really important. So the examination, the history, ECG, I love an ECG, okay? Deliver your meaningful interventions as quickly as you need to, okay? Do what you need to do. Don't worry about anything else. Everything else can come later. And then, obviously, the final thing is that there's no survival to hospital discharge without you guys bringing them to hospital live first. All right? So thanks very much for all the good work, and I'll see you around. Okay.